Surgical aspects of burn care. This is a presentation really outlining specific processes to Shriners. Some of it's general enough that it can apply to other operative suites. However, just please keep in mind, especially our audience at home, that these are specific procedures to Shriners hospitals for children. So we're going to talk a little bit about our team members, what preparation before the OR procedure looks like, ways to keep a patient warm so it doesn't just happen in the acute phase, types of excisions, type of wound closure, different equipment that you'll see, dressings, and then PACU versus ICU. Basically, where do patients go after operative intervention? I do want to mention also, if you want to spend some time in the operating room for like a day, you want to see what that process looks like, how the other half lives, just let us know. We can definitely facilitate that experience. Right now, scheduling is a little funny just because all the construction, we have one of the ORs down. But if you want to come in and do a day in the OR, seriously, just let one of us know. It's going to do a lot more for your knowledge and education than you'll get from a 30-minute presentation. All right, so about our team members, each member of the team has a task to perform, all right? The common goals of the OR team is the effective and safe delivery of care. It also needs to be timely. A lot of OR you'll hear like OR start time or wheels in, wheels out, and those kind of phrases. It's because time is our most valuable resource. We bring patients in, we only have this pocket, this window in which we can operate. If we operate beyond that, well, now we don't have the staffing or the resources to take care of that next patient. And so that patient gets canceled, and then Rebecca's pulling her hair out wondering what the heck happened. So we want to ensure that we're timely and efficient in everything that we do. It all starts at the very beginning of the day, right? All that preparation and that first patient come in. If that one's delayed, everything downstream is as well. Our team members will include anesthesiologists, surgeons, nurses, scrub techs, some crazy educator that only comes by when they have food. So it takes a team approach. This is a great image. It's not what your typical OR would look like, but you can see how many people are involved in the care of this patient. And let me tell you, we pull out all the stops, right? We're not just gonna, patch it up, let's hope for the best, conservative approach. No, we're gonna get all that tissue that we need to excised off. We're gonna cover those wounds as much as we can. That's why we need our own tissue bank, because we wanna ensure we can bring as much care as possible to this patient, not just in the form of resources, but in the form of people. Anesthesiologists are here. Intubations, they help us put lines in, they're going to help us with the sedation through the procedure. And remember I talked about we balance, we walk that thin line between pain control and then independence. Well, anesthesia walks that fine line between anesthesia and death. A little bit more will push them over the edge. Well, more than likely, a little bit more and they're going to be incapacitated for a longer period of time. But, these guys, they're the lifeline in the operating room. Remember, if we're doing our ABCs, airway comes first, and you lose that, you lose everything. They're here to induce, maintain, manage anesthesia, like we mentioned. Also help with line placement, so not just peripheral, but your central arterial lines, dialysis catheters, etc. Maintain fluid and electrolyte balance. So they're the ones in the OR who are watching the patient a little closer, just like you would at the bedside, right? So their role is to monitor the patient's airway, also their electrolyte balance and things like that. Things can actually change very quickly in the operative suite. I mean, think like extreme blood loss or the amount of fluids that patients are getting, or the feeds have been stopped. Like there's a lot of things that happen when the patient's in the OR that'll affect your electrolyte balance, but also homeostasis in general. Monitor your physiologic functions, and then replace blood. And sometimes it's not just 1 or 2 units. We might have a massive transfusion protocol. They might even be giving blood under pressure bags. Like we use to run our saline for our central and arterial lines. They're running blood through that in extreme cases. Surgeons are here not just to have a little fun, but also for surgical interventions, of course, for consents, orders for medications. So they help tremendously. I wouldn't say that they run the show. It's a team effort, certainly, but they're definitely an integral part of that team. Nurses. All right, we love our nurses. They are here for consents, history, physicals. They help make sure your room is prepared. They make sure blood and skin are available. We'll prepare medications, basically your non-anesthesia drugs. And then also things like antibiotics. So when you run your vanc over, because your patient's going to be in OR at 10 o'clock, the bedside nurse in the OR is the one who's actually going to hang it. Documentation is also important. The nurse will play a role vital to the smooth flow of events before, during, and after the surgical procedure. There's a lot of moving parts to all of this. Things have to happen exactly right. There's a lot of checklists and things like that that the nurse will run through to ensure the patient is safe and that care is delivered in an efficient and timely manner. Scrub techs, so these are individuals who help with the surgeon's tools or instruments, with equipment for the surgery. They can help with dressings, with supplies. They're going to also open and arrange the sterile field, and then also responsible for maintaining integrity, safety, and efficiency of the sterile field throughout the surgical procedure. So, I mean, you guys know surgical technicians, they're the ones ready to go. You almost predict what the surgeon's going to need for their case. And so you do that handoff. You're also responsible for that sterile field, which can be quite a difficult task, especially if you have a long case and you got to eat lunch. And, you know, what does that look like? Some of our nurses are trained to scrub. It's a pretty rare occurrence, but if they needed to, they can jump in at a moment's notice. Surgery involves preoperative preparation, intraoperative judgment and management, and then the postoperative care of patients. So remember, it's kind of like the wound assessment. You know, it's this continuum. We want to ensure throughout the whole process that we're astute, even though, oh, it's just another excision to bereavement grafting. We did that on the last, 100 kids. Well, every patient's important, and they will tell you what's going on, not verbally, but through physical signs and symptoms. So what does surgical suite preparation look like? It's hot. It is hot. The acute burn room is up to 94 degrees Fahrenheit. And we regulate the humidity, so it's not at least 100%. You know, it's, I think, closer to 60. It's hot. And we want to ensure we take care of ourselves so that we can take care of the patient. Now, why do we keep it so hot? Why even bother? Well, these patients are undergoing a hypermetabolic crisis, and in the operative suite, they're fully exposed. Therefore, we have to use external sources to maintain our patient's core body temperature. And that means we're going to suffer because of it. Now, again, we've got to take care of ourselves, right? And so in the OR, that means we're eating good breakfast, drinking lots of water. If we're bringing students in, we're letting them know, like, realistic expectations, what they have. The surgeons have these vests. Have y'all seen the vests? So basically, you hook up a hose, it's a water hose, and then water circulates through the vest. And so they can go and, do their operation and feel great. I haven't seen the nurse version. Where's the nurse version? And actually, to be fair, I haven't seen the surgeons use that vest either. I know it's available, but I don't know if it's like a rite of passage or something, but some people really just do well in the hot room. I guess it's good for your skin, as I've heard, so anyway. Prepare the sterile field. So again, very important, not just that you prepare it, but that you maintain it. We, as nurses, will assist anesthesia with the setup of equipment and supplies, including their anesthesia machine. This is where they can deliver oxygen and other gases, provide bag mask ventilation, that kind of thing. It's actually pretty nice, these anesthesia machines, if you've never worked with one. We can do intubation via fiber optics, which is pretty sweet, a lot of technology. And then level 1 or hotline setup also occurs. We want to arrange acute beds, gather surgical prep supplies, have warm solutions available. Why warm solutions? Well, because we want the patient to be warm, and if you pour cold bacons over their body, they can go from, 38, 37 degrees centigrade down to 34 pretty quickly. We want to have blood and skin available as ordered, so a lot of times this is done in the morning before the case, and it's a predictive model, which sometimes we're successful, sometimes we're not. but you want to have, it would be better to have it and not need it than the inverse. Also, we want to prepare medications and any surgeon special requests. That can be a certain kind of kit. So we have a Wong tray, and it's a certain plastic surgery type of tray that was one Dr. Wong loved, and we all love it too. And so someone may specifically ask for that, and we'll give them what they need. Here's an example of acute anesthesia table. So a lot going on here, but basically having the equipment you need to well, not oxygenate the patient because you don't see bag mask, but you can see the suction set up, you can see your circuit for your ventilator, just everything that they're going to possibly need throughout the case outside of their anesthesia machine. Pre-procedure verification. So this is a process, it's almost like a timeout, but basically all the providers are together and ensuring, are we doing the right thing for this patient? So it's the right patient, it's the right procedure. We also want to make sure that H&P is current, like are we doing this surgery for the right reason? Antibiotics, have they been administered? Are they even ordered? Blood available, type of skin and special equipment present. Oh, and there's something that's like key that is like ringing in my head right now. So for female patients over the age of 10, what else do we want to verify? Negative pregnancy test. So your HCG, you want to ensure it's negative as well. And granted, that's a clinic process. Oh my gosh, I thought 10 was too low. But yeah, I think it may even be lower at 8. And as controversial as that may sound, we still want to ensure that we're doing the test to ensure that we don't take a patient to surgery that has a little baby growing inside. All right, nude weight, aka trauma naked. So we have beds that weigh the patients, but remember, it's got to be zeroed with whatever equipment you're going to have on it. You can't just like add bed sheets, after you've zeroed it and hope for the best. So these will prepare. The patient gets stripped down. We call it trauma naked, just completely exposed, which is what you want for surgical intervention. And that way we can get a true weight. A lot of times you'll find with your daily weights, especially if you have a lot of dressings on or if you have some splint that you can't take down, those are not accurate. So OR weights need to be much like a clinical weight in that it is exactly what the patient weighs when they're completely naked, no devices, no dressings, that kind of thing. All members of the OR team will assist in surgical prep of the patient. If that scalp is a donor site, it would be shaved with razors. The entire body is washed with HibaCleanse, then betadine, scrub solution, and then rinse with warm sterile water. The table is draped out of a sterile field, and then the entire body is dried with sterile towels, then covered with warm sterile sheets. So this is the prep of the patient. And they talked about HibaCleanse, betadine. I think that has a lot to do with our low MRSA. It's just like how well we wash the patients. But think about how important this process is. These patients, yes, they have burn wounds that have, infectious material, but they're not sterile by any means. So if I go and I make incisions over where I'm going to take a donor site, even if it was just normal flora, I've just introduced, this new wound, and opportunistic pathogens can now take over. So by doing this wash, you're essentially creating this clean slate on which to operate. So how do we keep the patient warm? Well, there's a lot of different tools. Ambient heat, as I mentioned, 90 to 94 Fahrenheit in the operative suite. This is a OR warmer. So you set that up, and I believe it works like a hot dog system, similar to what we have down here. Where basically you have a blanket, you hook up the duct to it, blows up with hot air, you keep that over your patient. Let's say they're operating on the arm. Well, the arm's exposed, they're doing their thing, everything else on the patient would be covered. You can also use things like IV fluid warmers, which sometimes you'll see in the ICU, especially in the resuscitation phase. Sometimes we'll use those. The problem is they have, well, one, you've got to know how to use the equipment. I think that's probably things that we've run into a lot, just because we don't use it that frequently. But also, it takes a while to warm up your patient. And so you may find some other warming measures are more effective. Now, if you do a multimodal approach where we're maybe hitting this while we're keeping them covered, and that way it can be part of a bundle. rather than having one intervention. We also have these warming lights. However, those are becoming more and more out of favor. Basically just because manufacturers aren't making them anymore. So we used to have these portable things you could drive up and put over the patient bed and use that ambient heat to keep them warm. Those just are becoming harder and harder to find. So if you guys are looking for a new $1 million idea, well, someone already took it, and apparently it's not that popular. But I don't know. Maybe we'll get some more warmers out of the deal. Speaking of warmers, this is a fluid warmer. You'll have something very similar in the ICU to keep blankets, Dakin solution especially, warm. And then on the right, here's another example of that fluid warmer. Types of excisions. So you'll see escharotomies. In fact, y'all have probably seen those on the unit. Pretty graphic, very important procedure, but my God, it is just so hard to witness. But just know you're relieving that pressure and the patients are able to have good vascularity, good circulation at the expense of some pretty gnarly scars. Tangential excisions, facial excisions, just kind of depends on where you are, your depth, and then we may even do amputations, complete amputations. That important considerations there, obviously function, life after injury, all those things are very important. Also, your weight changes. So if I do a significant amputation and our patient's coming back from the OR, we might have just hacked off 10 pounds. And not like, oh, Jenny Craig or whatever, but, they lost a leg or something. So we need to, at some point, get a new clinical weight because the patient's weight has changed dramatically. Oh, but then another curveball, their circulation hasn't quite caught up with the lost weight, so where is that happy medium? And so those are questions that you should discuss with the provider, with the pharmacy team, to ensure that we're giving the right drug dosing. So I talked about early excision grafting. This is such an important process. We get rid of the dead tissue. We're reducing energy requirements so they don't have to work as hard. They don't need as much water, electrolyte, and protein because they're not working overdrive to fix this problem. Decreases wound infection. You'll see improved adherence of AUTOGRAFT. There's a reduction in pain. There's enhanced functional results. There's increased survival rates. If you could tell me what it doesn't do, right? Like, there are so many benefits to early excision and debridement. Until we hit the next evolution in burn care, this has been one of the most substantial benefits in the evolution. So as I mentioned, escharotomy is pretty tough to look at, you're going to see a lot in this course, so just kind of bear with us. It's the nature of burn injury. Escharotomy, essentially what they're doing is cutting through eschar in order to get to viable tissue as a means to reduce pressure against the vascular system. So for example, let's say in my arm I had a circumferential burn around the bicep. Well, if it's deep enough, what's going to happen is you're giving me all that fluid that I need. That fluid's going to build up at the site, all that inflammation, until it's pushing on my brachial artery. So much so that all the flow downstream becomes impeded. So now, in order for me to have that release of pressure, I either have to hope and pray that my edema is going to go away before I lose my hand, or the medical team is going to have to go in and do this procedure called an escharotomy in order to relieve that pressure so I can restore circulation, so I can save my hand. And that's a real possibility in our patients, especially those that are getting delayed in transfer and maybe they don't have the equipment like a Doppler to test the extremities and make sure the pulses are intact. This is a very important procedure. It's a little intimidating, especially if you've never seen one, but we're going to talk a little bit about it. Again, you'll have a compartment syndrome because of that circumferential burn, extracellular, extravascular fluid within that confined space. Assess for pain, right? They'll get this really sharp pain. Absence of distal pulses, changing of extremity sensation, or poor chest wall compliance if it's a chest or an abdominal. And speaking of that abdominal or the chest compliance issues that you might have from a burn injury, if this person has a circumferential burn around their chest, they may not be able to breathe after a certain point because all that pressure is going to be pushing against the lungs. and they won't be able to pull enough tidal volume for life. And so at that point, we actually have to go and do abdominal compartment syndromes in order to relieve that pressure. The excision of burn wounds. So a tangential excision, you're only removing non-viable tissue, sparing as much dermis as possible. You can use things like a Watson blade, which is what you see here. This is a WEC blade. Used over large flat surfaces. The Goulian blade is used over bony prominences. And then a dermatome. Now, a dermatome is essentially, it's like this on steroids. So it's a nitrogen-powered skin exciser. And so they run it up to their nitrogen source, and they go in, and the blade works, and you run it against the skin, and it'll go down to a certain depth. So they essentially are measuring the level of the eschar, go down to a certain depth to where it's just viable wound bed, and then that's what they drive over those burn wounds, similar to what you see here, to get to that underlying viable wound bed. That viable wound bed is what you need to then place graft. So you want to rid all the dead material, but you want a good anchor point for what comes next. Here's a VersaJet. This is a tool to clean the patient. I'm actually not sure to what extent. I do know I believe they clean the wounds with it, but I don't know much more beyond that. There's a special solution that goes with it. Okay, so a fascial excision, again, goes deeper. So for burns that extend into the fat and the underlying tissues, fascial layer is well defined, providing optimal excision and grafting with minimal blood loss. So they can go in, they can take out this whole section, and I mean, you've seen it sometimes where, like, you know, part of the butt is completely missing, and it's because they had so much that they had to excise out to leave that underlying wound bed around it. Amputations, unfortunately, it can be a common occurrence in burn injuries, especially electrical. The reason with electrical, you have what's called the iceberg effect, where so much of the damage is underlying. It's not on the surface of the skin, but everything underneath. So if you think about that guy who, I mean, this is kind of classic, I guess. He grabs the high tension wire, and that electricity goes through their body and then out one of the contact points. So here, at that high voltage, that's where you're going to see the greatest damage. And it's going to be, you know, not just the outside surface of his hand, but everything underneath. And then it may even follow the bone, if not the tendon and ligament, the bone, all the way out of the body. And everything along the way has been decimated. So your muscles, your tendons, they're going to be superheated. It may actually suffer a thermal burn injury. Your nervous system has this like huge surge, and so you'll see things like kinetic problems where they don't move right. It can affect, you know, the nervous system to the point that they have altered mental status. So that has just a huge impact on these patients. Amputations can definitely occur, especially with high voltage injuries. All right. We will also do amputations, those with deep thermal injuries, if it's beyond repair. Basically, you can only go so far with your excision, right? And if you can't go any further, unfortunately, you will have limb loss. We want to preserve the limb length to maximize function. So, you know, there's definitely a big difference between above the knee and below the knee amputations. This is true for any patient, really. You want to maintain as much function while erring on the side of safety, because sometimes we amputate because like a massive fungal infection of the foot, and if we didn't amputate, that fungal infection will take over the whole patient's body and they'll die. So, you know, it's kind of a game of, you know, risk and benefit. You do a cost-benefit analysis. Then we'll transport that specimen to pathology to determine you know, what kind of infectious disease was lurking within. Shaving the scalp. So this has actually become less common as we've moved away from scarlet red and more towards Xeroform as our dressing for donor site coverage. However, it still does occur in some cases. Essentially, the head is nice for donor site because it's a thicker skin, hair would grow over, so any scarring would be covered up. It's highly vascular, so it heals quickly. So it's been a really nice donor site location. But it comes at the cost of shaving a poor child's head after everything they've been through. By the way, we're going to take away your identity too. I mean, seriously, it's a lot, especially for our little girls that go through this experience of burns. It's a necessary part, or it was. I think as we evolve in burn care, we find dressings that can help us manage without these other complications. We just find better ways over time. And again, commonly from the scalp, and listen, I know this is a pretty graphic picture, but this is an example of how you actually will harvest skin autograft from a patient's scalp. All right, types of wound closure. So generally there's definitely more than 4 types, but we're going to talk about 4 types today. Autograft is from the patient's own skin, and that is a review because we just covered it not that long ago. We'll take those in surgery. They showed doing it from the scalp. Sometimes we use the thigh. Basically, the patient's own skin, it's the best skin. However, it's the most valuable skin too, because you're creating a wound to place it. They have to have more surgeries to take more skin. So a lot of times you won't actually see autograft in the first surgery. What they'll do instead is put on a temporary covering while the wounds are healing, declaring themselves, maybe because we're ridding of infection and that kind of thing. So HOMOGRAFT is probably something that you'll see more commonly. HOMOGRAFT is cadaver skin. And again, we have a tissue bank. They process donors. They give us this nice, clean sheet of HOMOGRAFT. And then you can place that on your patient. That's a temporary covering, meaning it's only going to hold its place at maximum probably 10 to 12 days, usually not even that long. A lot of times by that point, they've already had an additional operative intervention. They'll go in, they clean the HOMOGRAFT off, and they may place autograft at that time. So why wouldn't you just use autograft in the beginning? Well, again, it has to do with the patients come in, they have a brand new burn injury, there's already been enough time for some infection to take hold. We haven't even really cleaned down to the viable wound bed yet. So we want to do that first, put some HOMOGRAFT, give it some time to heal, and then we'll come back a lot of times with that second surgery to then apply the autograft. Now, Xenograft is much like HOMOGRAFT in that it's a temporary covering. It's pigskin, actually, has a very similar structure to what human skin does. And Xenograft has some of the benefits of HOMOGRAFT. So you get that covering. It helps with fluid loss. It helps with temperature management. But Xenograft is rejected more often than HOMOGRAFT. So the patients tend to not like it. And it usually only lasts like maybe 3 to 5 days instead of HOMOGRAFT, which can last a little bit longer. Some patients will reject it fully to where not only will it not adhere, but they will get these extremely high fevers because of it. Amnion, I think Justin did a pretty good job of describing this. Not on eyes, so if the patient has corneal abrasions from a burn injury to the eyes, the face, the back, and especially in younger patients, we'll use amnion. It's something, if you ever become a mom, that you can actually donate. So at UTMB they ask if you'd be willing to donate amnion, and this is the kind of thing it would be used for. So just something to think about. This is an example of autograft. Basically, we're taking it within the operative suite, and they used to bank it, which is what you see here. But now they take it off, they clean it real quick, and then they can place it somewhere else on the patient. Compared to, they're showing you 2 different types here. It's really hard to see, especially with the light. So sheet autograft is essentially a solid piece of skin versus meshed, which, I mean, you guys know meshed. It's like that crisscross pattern that you see a lot of times. So what's the difference? Why would you not just use meshed everywhere? Well, meshed is nice because that 1x1 sheet of sheet autograft that you have, you can put it through a mesher, and then now we can expand it up to 10 to 1 really, but generally anywhere from 2 to 4 to 1. So we'll have 2 to 4 times surface area that we can now cover. But at the expense of cosmetics. So if it was my face or my hands, I would much rather have sheet autograft because it will give me this nice, smooth, appearance, or at least as much as we can hope, right? Versus that meshed. So you'll see meshed everywhere but the face and the hands. And it makes sense, right? Like your face, it's the postcard to the world. Someone described it. I always like that. And your hands, the same thing. We talk with our hands. We generally don't keep our hands exposed, that kind of thing. So in our big burn injuries, you'll find that we use mesh. We got to cover a large surface area, except when it comes to the face or the hand. Here's an example of a mesher. You dial it to your settings. Some of them can change. Some are built in, like a 3-to-1. You put your skin in, you rotate, and it's meshed on the other side. Pretty straightforward. I think we did a pretty good job of covering those. I did want to mention, so sometimes you'll use HOMOGRAFT and AUTOGRAFT in conjunction with each other. So AUTOGRAFT's a lot more sensitive, right? So it came from the own patient. It's a little more delicate. It's also generally going to be at a higher ratio. Because it's more valuable, there's not as much. We'll a lot of times do that at 4-to-1 ratio. Well, homo, I'm not saying like, oh, there's all these donors and we just waste all this skin, but we might, do 2-to-1 instead of 4-to-1 on homo, which is stronger, right? It's going to be a more rigid structure. And so what they can do is they can lay that autograft as the base layer of graft on the patient, and then the homograft overlays on it, and that helps to protect the autograft and, the surrounding area as well. So you can find a lot of benefit by combining some of these therapies. Here's an example of Xenograft, and it's kind of got this classic peel off the edge. And what you'll find is over time, that whole layer starts to break away from the patient. And that's why it doesn't last, more than 3 to 5 days, is because it just continues to push off and off the patient. HOMOGRAFT can actually incorporate, and we have to go in and like scrub it out because you don't want it to, since it's not the patient's own skin. Oh my gosh, Meeks. So Meeks is literally taking your skin and then making it into the size of multiple small stamps. So this is like a 1 foot by 1 foot square, and you can see all the little dots that they have in it. So what they can do with this is essentially take some skin, expand it 9-to-1, but it's extremely delicate, right? Like I just told you, 2-to-1 or 4-to-1 is delicate. Well, 9-to-1 is even more so. You can cover a large surface area. The big thing here, though, is that your patient pretty much has to be immobile, because any shearing forces will destroy whatever's there. So it can be extremely difficult to have successful take with Meeks. I think we've only done it twice in the last 10 years. It is very much a last-ditch effort. We don't talk about it in this presentation. There's also cultured cells that they can do, where essentially they will put skin in a petri dish, grow it, and then you can apply it much like you would autograft. So there's a lot of different techniques. These are just not something that we will generally use. So how do you secure it? You guys know firsthand. Staples, my goodness. I didn't know there were so many staples. We probably keep the skin staple company in business. So staples generally are what we use to apply graft, except for the face. So it's like the plastic surgery, no, you don't staple the face. Instead, those should be sutured, or probably more commonly, you would see something like this, Artise, which is basically a high quality biological glue. And so we can adhere the graft to the patient, especially those sheet autografts, without the need for staples or sutures. Hemostasis is important, especially when you're taking donor site. God, can you imagine? So epi spray, they literally have a bag of sodium chloride mixed with 30 milligrams of epi, and you spray it over the site. So let's say we took a large donor site from the back. They can go and spray it, and it'll help reduce the bleeding. Pitkin solution. This is something when we would take donor site from the scalp commonly. They would actually have a syringe filled with this solution. There's a little needle on it, and they would inject under the scalp all the way around, almost like you would a local anesthetic. But what it would do is it would actually help separate the dermis and the epidermis so that when they went to shave, it was kind of this nice clean pool, and it helped to reduce blood loss as well. So pretty intense. Like I said, I worked OR for a day, and I was like, this isn't for me. And I'm sorry to all my OR people out there. You know, there's a special place for everyone. And then topical thrombin, same thing there. We can use that to help reduce the blood loss process. Tourniquets for extremities with blood loss. Yeah, tourniquet times are a real important consideration there. Electrocautery, so this is the tool. You guys are probably familiar with it in the ICU as well. You can run your Bovie with it along with other surgical cutting instruments. And electrocautery is to help basically after you cut to then cauterize the wound. Dressings, we've talked extensively about these, so I'm not going to go into any more detail. Here is what is affectionately called a poly party. One thing I do want to mention, if you notice they're all in sterile technique, that's really how it should be done. So poly is a sterile medication. Your fine mesh gauze comes in sterile preparation, so you really want to maintain that sterility because that's what's going to be directly put on the patient's wound as well. And so you'll see them practicing good sterile technique in which to do that. Some dressings that they use back in the OR. Just remember, like Justin said, you want to ensure you're evaluating a dressing's effectiveness. Some dressings tend to work better depending on the patient's needs, like if they live 4 hours away and they are not coming every day, we might choose different options. And again, we're not endorsing any particular product. This is just things that we use. All right, so post-op, how do you know where your patient's supposed to go? Real-time triage, it's pretty easy. Basically, they go back to the ICU if they are intubated, and that may be intubated after the case, right? They didn't go intubated, but they came back. That happens sometimes. MDRO, so we don't want a multi-drug resistant organism spreading all around the PACU, so we'll get them back to their isolation in the ICU. And then also if the patient has a temperature, so if there's any sort of issue, febrile, we're not sure, there may be some issue from the surgery that needs further intervention. PACU, if our nurse, this could be a PICU patient, but if the nurse has a 2-to-1 patient assignment, generally means not a critical. They can go to the PACU before going back home to their ICU room. That's not always true. If you ever have any concerns, check in with the charge nurse. Or it could be an outpatient that has no complications. So no fever, no respiratory compromise, that kind of thing. They'll hang out in the PACU until they're awake. Basically, we look at the Aldrete Score, and if they score over a 9, see you later. Have a good life. Just kidding. Remember, we treat them for the lifespan. All right. Speaking of PACU, we have our anesthesia team. We're going to talk about the goals of the PACU patient, the Aldrete Score, PACU procedures, and discharge criteria. I'm going to check just the time real quick. All right. Since it's 3:37. We'll probably skip focused altogether. I'll finish this one. All right, goals of anesthesia. Depressions of consciousness to allow tolerance of noxious stimuli, full-on analgesia, so it's the removal of pain, skeletal muscle relaxation, and then depressed reflexes. So you really want to bring your patient to a certain level so they don't feel what we're going to put them through with this procedure. There's different inhalation anesthesias that we use. These are a couple of volatile anesthetic agents. We can also use nitrous oxide. Generally that's more procedural based rather than used as a primary means of anesthesia. We can give IV anesthesia as well. Ketamine's a complete anesthetic, although you can give low dose to maintain analgesia in a moderate sedation. What's nice again about ketamine is you keep the laryngeal reflexes. You have dissociation, which is actually a good and a bad thing. It's good because they don't know what's going on. Bad in the sense sometimes you can have Emergence Delirium complements those a lot. Propofol is an example of an induction agent, not an analgesic, helps to maintain anesthesia. All right, different stages of anesthesia. It's 1 to 4. Basically, you have stage 1, stage of analgesia, 2 is excitement, 3 is surgical anesthesia, and 4 is stage of circulatory and respiratory collapse. So you want to avoid stage 4. ASA and ASPAN standards, we need to monitor during the operative intervention things like oxygen, ventilation, circulation, level of consciousness, temperature, pain comfort control, sensory and motor function, patency of your tubes, condition of dressings, eyes and O's, and emotional status. Now, I know we're not OR nurses, at least not in the room today. However, these also apply during your procedural sedations. So this can still be relevant to you even if you are not a post-anesthesia nurse. Care for the PACU patient, we want to maintain patent airways, allow for the anesthetic to dissipate, so time, allow vital signs to stabilize. We're going to provide pain relief, assess physiologic function, and then quickly recognize and manage any complications. Aldrete. So this is really your ultimate determinant on whether your patient's ready for transfer. We're doing a score. It can be anywhere between 0 and 10. Or no, actually, I'm sorry. I think it goes up to, yeah, that's right, 10. And that'll help determine, again, whether they're ready or not. So what you do, essentially, is you run down this list. Okay, patient's starting to wake up. We've gotten their oral airway out. Maybe they're starting to talk even. So, hey, you're talking, let's, more walking. Just kidding. So we want to make sure they're safe. Activity status. So generally you want them to move all extremities. That'll get 2 points. You want them to be able to breathe and deep cough. So that's another 2. You want your blood pressure to be back at baseline, or at least pretty close. To do that, you get 2 points. Level of consciousness. So this is one we can kind of bend a little bit. You know what? They woke up and they're asking for mom, and then they go back to sleep, but they're protecting their airway. They really scored high everywhere else. Maybe we let this one slide. So 1 or 2 would be okay. And then skin color. I definitely want my kid pink, warm, and dry. If they're pale, mottled, cool, or jaundice, or cyanotic, I hope that's an alert for, hey, something's wrong, and we may need to intervene. It depends on the patient. Most of the time, we definitely would. As far as your assessment goes, so it's similar in your, when you're giving sedation, you want to follow, every 5 minutes when we do our sedations. But for doing post-anesthesia assessments, it's every 15 minutes the first hour, every 30 minutes for every hour, or for the next hour, and then as ordered following that. So just something to keep in mind, especially if you're ever working back in the PACU. Pain assessment, so we use 2 different types, observational pain scale and then pain scale for intubated patients. I say we do 2 different types. We do more than that. We do a Long-Baker FACES scale, and then there's another pediatric one that we have recently introduced. The name escapes me. All right, thermoregulation. Again, we got to keep it warm, not just in the OR, but in the PACU for some of our patients. So we have different warming devices. We have overhead heaters there. We have the bear huggers, that kind of thing. We also want to monitor for hyperthermia, with all these heating devices, plus these burn patients may have infection, etc. Emergence delirium, this is unfortunately not uncommon. You guys might see it in the ICU, especially with ketamine use. It can occur with other anesthetics as well. It's a dissociative state of conscious where the child's inconsolable, irritable, uncompromising, uncooperative, thrashing, crying, moaning, or incoherent. So they're just not themselves. They've had this experience where maybe they had a nightmare from the anesthetic that we gave them. They emerge from it and they're just completely delirious. Now there are some ways that you can help abate this. One of the best ways is that if we give midazolam in front of whatever the anesthetic is. So emergence delirium you see a lot of times with ketamine. Well, if you supplement that Versed on the front end, a lot of times you can reduce or completely eliminate that emergence delirium. And so a lot of times you'll see those ordered together, And they complement each other well, but especially for that reason. All right, so how do we awake the patient? Nice and easy, so no sudden, changes, right? Calm, quiet atmosphere, protect from injury, discontinues airways as appropriate, discontinue oxygen, assess your patient's status, encourage to turn, cough, deep breathe, provide comfort and support, and then encourage visitation with family. So we want to keep them engaged, but not loudly. Basically, these patients, if you let them, they'll sleep the whole time, right? But we don't want to get in there and sternal rub and, hey, come on, get out, we're waiting on the next one. So there's a balance in between. A lot of times, especially in our patient population, you get mom or dad in there, they said bye, they want to be with mommy, they want to be in their room. They don't want to be surrounded by me, okay? So we can get them out that way. Send Clayton over and they want to leave. PACU procedures, some small surgical procedures for patients with a high level of anxiety and a low tolerance of painful stimuli. Now the reason we would do it in the PACU versus the treatment room is we'll have more access to anesthetic equipment. So maybe we'll give that nitrous oxide in addition to the fentanyl pop. Or maybe they do a little bit more, or some strong pain medicine, that kind of thing. So you have just better tools at your disposal depending on the situation. We can do, again, anesthetic procedures. We can do conscious sedation. By and large, though, we're doing those on the unit. Those are led by the charge nurse. And we'll get you up to speed pretty soon, actually. Generally, about a year in is when we start training you guys on airway and moderate sedation. PACU procedures are surgical procedures, so we need to adhere to all the documentation and legal guidelines that you would. Remember that Aldrete Score is really important. And not just from a documentation standpoint, but how's your patient doing? Yes, make sure your patient's stable. Make sure the unit nurse is ready to accept the patient. And oh, isn't that nice that they actually wrote it in there instead of just bringing them down, right? And it does happen. We do the best we can. And then a physician's orders for discharge. So just because, hey, they look good to me, the anesthesia provider needs to come in and let us know that they feel the same way. All right. Any questions? All right, so again, looking at the time, we're not going to be able to get the